introducing Dr. Priyanka Khandelwal to you. She is a pediatric nephrologist with an MD and DM in pediatric nephrology from AIIMS, New Delhi in India. She's a clinical fellow currently in the complement-mediated diseases fellowship program at the Hospital for Sick Children, and has a long-standing and well-documented research interest and clinical interest in complement-mediated diseases, including aHUS and C3G, as well as in chronic kidney disease in children. This is a very brief introduction, and I was told to not go beyond that. An option was to read it twice, which I'm not going to do. You're in for a treat. Dr. Khandelwal comes really from the place that has taught the world about autoimmune aHUS, the antibody-mediated form of aHUS. You will really learn it from the top here. If you bother to look into the literature and looked up original papers on this topic, you will find 8 out of 10 carrying her name. So this is a real treat, Priyanka. It's a real pleasure to introduce you and to have you here on stage.
Thank you very much, Christoph. It's a privilege and a pleasure to be here amongst all of you within this aHUS family. And thank you, Christoph, for not reading my bio twice. So I'm going to speak on anti-factor H-associated atypical aHUS. And the aHUS Alliance website calls this a disease within a disease. And this is actually what it is. It's a very distinct entity. And because it's a distinct entity, that's why there are more questions than answers. And I expect to be grilled at the end of my talk. So I'll begin without further ado. And also, you would be happy to know that I will not be showing the complement cascade in my talk, but instead I will trouble you a little bit more by talking about factor H in slightly more detail. Hopefully it's not too much, and Christoph told me, please don't go overboard, and so that's what I'm trying not to do. So the factor H, I don't need to introduce factor H. It's the most powerful regulator of the alternative complement pathway. And this is the factor H with all its 20 domains. So the C-terminal end of factor H, and this is the N-terminal end. So the reason I'm showing you this figure, and Christoph in the morning also showed us the entire factor H with all its genetic variants located on the C-terminal end of factor H, and showed us that in various talks since morning, you've heard that the N-terminal is the one that controls the cofactor activity or the fluid phase regulation of C3 convertase and converts C3b into inactive C3b. So that's the N-terminal that does that. And the C-terminal basically binds on top of the cell surfaces and protects these cell surfaces from complement activation. So there are distinct roles of those two ends, and this is the normal condition where factor H binds to the cell surfaces and protects these cells from activation of the complement. But when you have antibodies to this factor H, what these antibodies do is that they bind to the factor H and leads to the formation of something called immune complexes. So these form complexes with the factor H. And so these are the immune complexes, and these can basically bind to various regions on the factor H and impair both its binding to the cell surfaces as well as its regulatory role. So the ability to protect cell surfaces against complement activation is therefore inhibited by the presence of these antibodies. And so over the years, various authors in their various publications have tried to look at where exactly these antibodies bind on the factor H molecule, because it's important, like I said, different domains, different activities. So, and they have consistently shown that the C-terminal end is the area where the antibodies would always bind to. So therefore, they would inhibit the surface recognition of the factor H. But in addition, they can also bind to other areas of factor H that are responsible for the cofactor activity as well. So therefore, definitely the C-terminal end that consists of these SCRs 18, 19, and 20 are extremely important in the context of this talk. And over the next couple of slides, I will try to answer the toughest questions first. And so the first question is, why do these antibodies occur? And I will try to answer them. There's not a complete answer for this, but I will try and present whatever is known and all the hypotheses that are in the literature. So the reason I'm showing you this figure, and also Christoph has shown this in his slides today morning, is that he mentioned that so these are he called it, I think, the siblings of factor H. So these are actually the siblings because these are short but they are related because the CFHR proteins 1 to 5, the C-terminal end of factor H that I mentioned, which is important, SCRs 18 to 20, have a very structural similarity with the C-terminal ends of all of these proteins here. So you can see that when we talk about complement factor H, the C-terminal end 3, 4, 5 has a very high structural homology to the tune of 100% to 98% with the complement factor H C-terminal area. And so this is important because you have these antibodies that are in your blood, which bind to the C-terminal end of the factor H. We know that. And you have another protein so in the blood that has very high structural homology to the same area. So definitely there has to be some functional consequence of this. And so authors over the years have tried to figure this out. And this is, again, a difficult figure to explain. But what I will tell you now is that if there's a patient of atypical aHUS, and in that patient we find that CFHR1 is completely absent, the odds of having antibodies to complement factor H is 150-fold. So therefore, CFHR1 deletion is basically a very strong association, has a very strong association with antibodies to complement factor H. And that has been now consistently shown across multiple studies. And the odds of 150 is basically a pooled odds from all of these studies that have looked at the risk of having these antibodies in patients with aHUS who have a complement factor H deletion. So when someone asks me that if you have antibodies, is this genetic or is this autoimmune? I would say this is autoimmune because this is not a genetic, it's a susceptibility factor. It's not an etiology. But having said that, I would again take you through data that suggest that there might be some functional implications of the CFHR1 being absent. So this is slightly confusing to understand, but what I would like to drive home the fact that there is an definite association between the CFHR1 deletion and complement factor H. That's the bottom line. What's this figure here? So this is called a genetic recombination. So somebody would ask, how are these CFHR1 deletions happening? So genetic recombination events are basically when you have, so the DNA of the parents basically mixes and matches and therefore forms a brand new unique genetic information for the child. So during this mixing and matching process, so that's mixing and matching is known as genetic recombination. So when this matching happens, sometimes it's not aligned completely perfectly well. And so when the genetic information of the parents are not aligned completely, it can lead to genetic deletions, it can lead to duplications, it can lead to genetic rearrangements. And so these aberrations, the matching happens in areas where there is very high structural homology. So now going back to our structural homology slide, this one, we know that there's a high structural homology between the C-terminal ends of all of these proteins. And so that's what I've tried to show here. These are the genes, and these red, green, and yellow boxes are the areas which have high structural homology with each other. So that's where the problem starts happening, because instead of recognizing the opposite end of complement factor H now, during these recombination events, this area will start recognizing this area here, which belongs to complement factor H related protein 1, so CFHR1. And so you will lose this entire segment of area, which comprises of CFHR3 and 1. I hope I've explained it well, but that's the simplest way that I could think of explaining it. So you'll have basically a chromosome which lacks completely CFHR1 and 3 because of these genetic recombination events, and you'll have a child who lacks this, who has complete deficiency of CFHR1 and 3 in the end. And so why is this practically important for patients to know? So again, Christoph today, when he was discussing this, these CFHR1s talked about something called hybrid genes, which are a combination or fusion of CFH with all these CFHR1 or CFHR3, 4, or 5 proteins. And so when these recombination events happen, Jackie in the morning talked about genetics, and she said that we do next-gen sequencing, and she did talk about a few disadvantages or limitations of these next-gen sequencing. And so one of the major disadvantages of this technique is that you do not get to detect the large deletions and rearrangements that happen in these patients. And so these are a very rare group of patients with aHUS that may have hybrid genes, not necessarily associated with antibodies, and they usually have a very severe phenotype, but you will not be able to detect them or diagnose them just by doing a next-gen sequencing analysis. For detection of those genetic rearrangements, you would need a whole new other test, which is called MLPA, and this is how it looks like. So basically you have probes that detect all of these areas that are unique and not really they miss out the structural homology, so there's no confusion. And so the area which is missing here on the slide, the print is too small, but it's actually a CFHR3 and 1 deletion. And so that's how it looks on the report that you get, and that's how you can make out that these patients have a complete deficiency of a particular complement factor H-related protein, and so hybrid genes are also detected in the same way. And so it's important, along with the next-gen sequencing analysis in all patients with atypical aHUS, that you also need to have an MLPA for the initial diagnosis. So that's important, not just for patients with antibody-associated aHUS, but otherwise also. Now, I did mention that the implications of having a complement factor H-related, so FHR1 deficiency, I did say that there might be some functional implications of this. So there have been many papers that suggest that because there's a structural homology between complement factor H and related protein 1, so also the function, they're also similar in function, but the CFHR1 is much less potent as compared to factor H. And so if the amount of FHR1 increases, it would compete with the action of factor H. Whereas if there's a deficiency, so this is the only paper that talks about the regulatory role of FHR1 on the terminal pathway. So just in easier terms, what this paper shows is that complement factor H basically inhibits the cleavage of C5. It prevents the generation of C5a and C5b, and also the deposition of C5b on the cell surfaces. It also inhibits the assembly of these MAC complexes and prevents the attachment of the MAC on the surface of the cells. So what it does, it basically regulates the terminal complement pathway. And that's the only paper that suggests this. So intuitively, if you have a deficiency of FHR1, the terminal pathway would be dysregulated. So that's the implication. And so it's not just the balance between FHR1 and FH, but it's also the deficiency of FHR1 alone that might lead to the dysregulation of the terminal complement pathway. But this is just one paper that talks about this. But then there's also a slightly different angle to this. So if I were to tell you that out of 100 normal individuals in this room who do not have aHUS, 10 of us would have a complete deficiency of CFHR1. So that's another fact to consider, that CFHR1 deletion is a polymorphism. It's present in 2 to 12% of the population world over. The frequency slightly... Yes. So it's present between 2 to 12%, average being 10%, and this frequency is almost similar across the globe when studied, and so alone CFHR1 deficiency is probably not enough to cause atypical aHUS, or probably even to lead to the formation of antibodies. So we don't know. So it's important to understand that it's a polymorphism, and it can be found in a very high proportion of patients, individuals normally as well. So then why do these antibodies happen? And so we come back to this infectious triggers and second hits that we have discussed in our previous talks. Yes, please.
Let's go back to the last slide.
Yep.
Did I see that correctly, that all the other ones are 10 to 25, but India's 56%?
Oh, so this is, I'll come to this. So this is the, this is the frequency of anti-factor H associated aHUS. And that's probably the reason I'm here today. This is the frequency of anti-factor H associated aHUS in India. So I'll come to that bit in a while, but maybe you can focus on this bit here for for the time being. So I was talking about the role of infectious triggers. So in the previous talks, Valentina, Jeve, Christoph, they have all spoken about the role for infectious triggers, and we understand that this is important, and this also happens in anti-factor H associated aHUS. So there's usually an infectious trigger, which is either GI prodrome or a viral URI. And in more than 50%, I would say even 60 to 70% of patients, before they present, manifest the signs and symptoms of aHUS. So on a background of CFHR1 deficiency, you have an additional hit, and that leads to the formation of these antibodies. And so this is data from India. That's the center that I was working in. I want you to focus on the gray bars in the panel below. So this is the frequency of antibody-associated aHUS that are reported, the number of patients that are reported every month. So you can see that there's a seasonality to this. And this seasonality has remained consistent whenever we analyze our data, in whichever year we analyze our data, right from 2007 to 2019 or 20. Whenever we have analyzed it, we have found that this seasonality exists. So patients start presenting to us in crops, in clusters in November, December, going on to January, February, March. And then after April, they decline. They don't present anymore, and in the summer months they're gone, and then we find them again in November, December. So there's a seasonality to this. Yes, please.
That's global or that's
That's in India. I don't think that I have read this literature anywhere else. It's just in India. We believe that this probably is related to the viral illnesses being more common during the winter months or the spring, whatever spring there is in India. But in the spring months, we think it's probably related to probably a viral trigger, and that's why I've put the slide here. But unusually, when COVID happened in 2021, so the blue bars here reflect the second wave of COVID in India, which was pretty bad, and the cases peaked in April and May. And following this peak that happened in May, we noticed a very unusual peak of cases in June, and five of these patients presented more than 6 years after initially being diagnosed, which is extremely unusual for these patients. And so we had this weird peak that happened in summer, which we had never seen before. And these patients either had COVID PCRs positive, like active COVID, or they had a family member with COVID and they had antibodies to the COVID. So we think it's probably COVID act as a trigger. And so that's why I'm talking about this here. And somebody also asked a question about, yes, please.
I'm just asking about varicella because I see it on the screen.
Yes.
Because I got shingles about 6 years ago.
Yeah.
And I was supposed to get the Shingrix vaccine, but I've been avoiding it because of the side effects. But I want to get the vaccines to prevent like shingles and potentially a trigger, but getting the vaccine, can that be a trigger?
So it's kind of a tricky situation here because we know that vaccination might be a trigger, but then we always, on an individual basis, we always consider the risks and the benefits. An example, I'll talk about COVID because that's the most controversial vaccine. So there's a paper not in aHUS literature but in TTP in adults where there's a large cohort of patients and they have immunized these patients, and they've found that some of them did have a recurrence or relapse of TTP, but majority did not. And so the risk-benefit ratio was actually skewed in favor of patients getting the vaccine rather than not. So I guess it needs to be considered on the individual patient's risks and benefits of getting that vaccine versus not getting that vaccine, and the risk of a flare based on what genetic variants you might have, what your diagnosis is, the etiology is, and other things. Hope that's clear enough. Yes, please.
Out of curiosity, are these patients that are on a medication?
These patients who had relapsed?
Yes.
The orange ones, you mean?
The ones that were, yes.
After COVID?
Yes.
No, so these patients were presented 2 to 6 years after presentation, and normally we stop immunosuppression after 2 years, so they were not on therapy.
They were not on like eculizumab or anything like that?
No, so I'll come to that in a minute. No, but we do not have access to eculizumab in our country.
Yes. Okay. So
but we usually manage.
potentially,
Yes.
If a patient is on eculizumab
Yeah.
and gets the COVID
Yeah.
vaccination, they should be okay.
Let's.
Okay.
Maybe I should refer this question to Christoph. In the discussion, maybe, because I understand that vaccination is an extremely important topic otherwise, and also discontinuation of treatment and other things related to eculizumab is important. So I guess in the next session. Yes.
Sorry, I have a question about the list of items on the left, like the first,
Yeah.
the first one, so the GI infection, and then all of the other ones underneath.
Yes. So these are yes.
And also, I wanted to ask about like, this is someone who has genetic mutations, but also could be someone who does not have genetic mutations, and these could just be triggers.
So the first part of your question is that these other things that I've written is the extrarenal complications that happen in patients with anti-factor H associated aHUS. So these are just the proportion of these. I'm not going into these in detail because they're not very different from what happens in anti-factor H negative patients. So that's the first part of your question. I'm not sure I understand the second.
So the bottom part of the table is what happens to the patient when they develop atypical HUS?
Yes, yes.
Oh,
yeah.
okay.
That's at the onset, like the extrarenal manifestations. Some you can have cardiac, you can have pancreatitis, hepatitis. So this is what happens at the onset of the illness.
Okay, but the first two items were triggers.
Yes, the first two items are triggers.
Sounds good.
I just wanted to talk about the triggers because overall the clinical features are not really that different between the antibody positive and the negative ones. Both of them have severe extrarenal complications, can have.
So in other words, if someone has atypical HUS, especially if they're off the drug and they get any infection, they should be on guard for that.
Yes, definitely. Okay, so we have talked about triggers, we have talked about CFHR1, and we have talked about it being a polymorphism. We have talked about the extremely important association between antibodies and CFHR1. So how do we link these two things together? How do we link infections? How do we link CFHR1? And this is where this paper comes in. So this is again just one paper, and I'll try and make this a little simpler for you. So what this paper suggests is that there are some pathogens that have proteins that basically bind to complement factor H and make this complement factor H change the conformation of complement factor H slightly. They basically bind to the same area where these antibodies bind to, by the way, change the conformation of complement factor H slightly to make it more similar. Although they are almost similar, but they make it even more similar to the complement factor H related protein 1, CFHR1. So now they're exactly similar. And so the body so if the patient has CFHR1 and also has this they call it neoepitope, this conformational change that the pathogen induces. So once those two are present, because the CFHR1 is already present, the body does not recognize this neoepitope on CFH as foreign. But suppose a patient does not have a CFHR1, any conformational change in CFH, the CFH protein that is induced, the body starts recognizing this as foreign because it has not been exposed to the CFHR1, and it doesn't know that this is something which is normal. So it recognizes this as foreign and starts producing an antibody response to the complement factor H. And so that this paper suggests that this is how you can link CFHR1 deficiency, presence of a secondary infectious trigger, and the presence of an antibody. So this is just an hypothesis and some evidence to suggest that these three things might be linked. I know I haven't answered your question of why these antibodies are produced, but these are the various hypotheses that are now known in literature. So I'll move on to a slightly simpler topic. So these are, I'll just present to you these patients that so these patients presented in 2014 back when I was doing my training. And suddenly in January of 2014, there were these 5 patients who presented almost within days of each other. They were between 5 to 11 years of age, and they all presented with abdominal pain and vomiting. One patient, you can see this interesting patient number 4, didn't even have any other symptom of pallor or reduced urine output or anything else. Had normal blood pressure, just some mild pallor, which is quite common in India, by the way. So just abdominal pain and vomiting. And as a resident, if you tell your professor that you would consider aHUS in a patient with abdominal pain and vomiting, he will kill you. So the only reason we thought this was aHUS was because of this cluster of patients who had presented before. And so And so I'll show you another interesting slide. So this is what Jiwei had shown you, the smear, the blood smear of the patients. And because aHUS is so common in my country, as pediatric residents, we are all trained to make the blood smears of the patients on our own and look it up before we get the formal pathology results. And any idea how long it takes for us to make the diagnosis if we were to look at the smear on our own? Any guesses? Yes, right away. So you just basically have to have a willing patient who's willing to lend you a drop of blood, and then you make the smear and you see it on the microscope and you see these broken RBCs, which are actually the hallmark of aHUS. And so all of us, all of these patients had features of severe microangiopathic hemolytic anemia. Even though they had such a benign presentation, their labs were suggestive of severe thrombocytopenia, low C3s. I don't have to go into the details. All of you are well versed with this presentation. And so in these patients, then the next step, of course, is to do an infectious workup. As you all know, the entire pathway, rule out STEC, rule out all other secondary etiologies. And the next step would be in these patients. What do you think the next step would be in these patients? It's the detection of antibodies to factor H for us in India, because it's so common, like you said, 56%. I'll come to that in a minute. So this is what I was talking about. So the only difference is that anti-factor H antibody-associated disease presents in slightly older children. There's a peak in adulthood as well, but because our center is chiefly, we were looking at pediatric patients, so we just got pediatric referrals. But it's mostly older children. They have severe disease, but their clinical features are similar to what a patient without antibodies would have. So you cannot differentiate just by clinical features alone. So you need this. You need an ELISA for detection of these anti-factor H antibodies. And this ideally should be done before initiation of plasma exchanges. So what's an ELISA? The reason I'm talking about this, again, it has practical implications. An ELISA is basically a test that detects, it basically catches these antibodies and measures these antibodies. So simply speaking, you have a well, you coat factor H. If you have any antibodies in your blood, these antibodies get bound to those factor H, which you've coated on the well. Then you have a secondary antibody to your complement factor H antibodies, that's the blue one here. And then this is the antibody that produces color. What do I mean by color? It's actually color. So this is the well, this is how it looks like. So the color is basically telling you how much antibodies you have in these various. So each well is one sample. So so to what extent these antibodies are present in these basically these samples. And so based on the intensity of color, you create a curve. Now this curve is created only if you have a standard. Now, what is a standard? That's where it gets interesting, because you can have different standards for different labs. And so if your standard is different, your antibody titer will be different for each lab. So each lab has their own known standard to create the standard curve, but the amount of antibodies you're measuring isn't necessarily on the same scale in different labs. So you cannot necessarily compare the level of antibodies in different labs, and this has important practical implications for patients with this disease. The second thing is that the normal threshold is based on healthy local controls, and there are even many labs that don't even run this, don't even have a threshold based on their own control. So this is an important step. And the third thing, as I mentioned earlier, is that the ELISA should be done before initiation of plasma exchanges. So now, anti-factor H antibody, the setup in my country, in India, in New Delhi, was established way back in 2010, and since then this has been we had been offering this to centers across the nation, and this was all being done free of cost. on the basis of projects, and we performed it every fortnightly, so every 15 days. And so the turnaround time is basically 15 days for these antibodies. And so why did we do it every fortnightly? This is the reason why. Because we had about an average of 35 patients with antibody-associated disease presenting every year to our center. So we had to do it fortnightly. And these patients presented every year, presented pretty much across the nation. And so by the end of 2018, we had 436 patients from 2007 onwards in our registry. Patients had high antibody titers. Our normal cutoff was 150. These patients had an average of about 10,000 anti-FH titers, extremely high titers at onset. But what's the situation around the globe? So the papers from way back in 2005, when this antibody was first discovered, there have been many papers that have looked at the prevalence. In European countries, it has consistently been in the range of 10 to 11%. In India, it is 56%, like I said. The most recent data from Egypt says that it's around 50%. Korea, another again 50%, China 48%, and so and recent data from Argentina, in fact, 20%. The global aHUS cohort estimates the prevalence of these antibodies at 23%. So the question is, are we diagnosing it appropriately? Is it being underdiagnosed? Should there be wider availability and rapid turnaround time of ELISAs to actually diagnose it better? I feel that in developed countries, because you have access to tests, and if it's been done appropriately at onset, you probably will not miss it. But definitely in other countries, in developing nations, in other nations where this test is not available, it's definitely being underdiagnosed. And so there should be wider availability of these ELISAs and a wider recognition that this is an important, distinct entity that needs to be diagnosed. And why should it be diagnosed early? Because the therapy is not just eculizumab or C5 blockade, it's also the addition of steroids and immunosuppression to get these antibody titers down and to make them stay down. So it has important therapeutic implications. And so going back to these cluster of patients that I mentioned, all of them had antibodies, and their titers was extremely high. We don't have access to eculizumab in our country, so we perform daily plasma exchanges. And so with plasma exchanges, plasma exchanges basically removes these antibodies, and so you have these antibody titers going down. Within 5 exchanges, they reach there's a clearance of about 80 to 90%, and they remain down. So, and there's data from from India suggesting that you can abbreviate the course of plasma exchanges. You may not need such a long course. You can abbreviate to 4 weeks of therapy and then basically be done with it and just maintain these patients on immunosuppression. And on the medium term, the outcomes look good with that policy. But that's just in countries where we do not have access to eculizumab. In countries where we have access to eculizumab, the situation is different, and I will speak about it in more detail because that's more relevant here. So 1 week later, with plasma exchanges, basically all of them went into hematological remission. Their anti-FH titers were down. They did or did not require antihypertensive agents, and there's no follow-up here, but I know that it's not published, so I didn't put it on the slide, but these patients are doing really well now. So this is the slide that Christoph kindly gave to me. These are the IPNA guidelines on the management of anti-factor H associated aHUS, and this is basically the gist of all this. So like I said, So for the treatment, there's basically 2 phases. One is induction, the other thing is maintenance. So induction is where you get the antibody titers down, or you prevent the antibody titers from activating complement, and you do that by either doing plexus to remove these antibodies, or you give eculizumab or complement blockade to basically block the complement pathway and prevent these antibodies from activating the complement. And you do that along with immunosuppression in the form of steroids and the addition of MMF. So this is induction. The goal of induction is to reduce the antibody titers or to block the complement pathway. And so, like I said, there's a protocol for plasma exchanges that is followed. And when it comes to complement blockade, it can be stopped when these antibody titers are low. And what's low? I'll come to that in the next slide. And then there's a period of maintenance, which maintenance is basically MMF for 1 to 2 years. And again, why 1 to 2 years? Next slide. So here's the interesting slide. So the first picture here is data from basically the numbers are here. So these are 386 patients with anti-FH associated disease at onset, and which have then been followed up for almost 10 years. And these are the levels of anti-FH titers. So you can see that the antibodies decline after stopping plasma exchanges, and basically when they are just on immunosuppression, they are not normal. Our normal range is 150, so this line here. So they're definitely above the normal. They do decline, but they remain elevated on the long term. So that's point number one. Point number two is, and these patients remain fine in remission. Point number two is that we have noticed that patients who have shown a relapse, so these were about 50 patients, 10 patients with relapse, 40 without. And the patients who showed a relapse had a high level of free factor H. Now, what's free factor H? Remember I said in the first slide that these antibodies bind to factor H and form complexes. Free factor H is the one that escapes these complexes and are just existing in solution. So when we have less free factor H, these patients are more prone to getting a relapse, basically. And so this is just a research test, and which has been just done in a subset of patients, but there's there is promise there to expand and to do this in a larger cohort to see whether actually this correlates with relapses and can guide therapy. The third figure is the most interesting and relevant. The relapses in these patients. 90% of these relapses occur by 2 years, over the first 2 years. Within the first 6 months, 2/3 of these relapses happen. So basically, our critical period is the first 6 months. If we have that covered, we have most of these relapses covered. And if we extend immunosuppression to over 2 years, we're basically covering more than 95% of the relapses. This figure was actually 99. After COVID, this decreased to 91 because these patients presented really late with 2 to 6%. So the spike you see here between 72 to 76, these are all post-COVID. So after 2 years, you have if you extend maintenance immunosuppression to 2 years, you have these relapses covered and you're safe. And this is not just data from India. We have similar data from the German-Austrian cohort, which enrolled a large number of patients, and they showed that the anti-FH titers again declined, not to the normal levels. They remained elevated on the medium term, but there was definitely a decline. Again, they showed that the first 6 months was crucial because most of these relapses occurred in the first 6 months, and all of these relapses basically occurred within the first 2 years. So we have data from 2 independent cohorts, from 2 independent centers, 2 independent multi-center cohorts basically, that shows that the relapse risk is highest in the first 6 months, extending to 2 years. And so basically that's the rationale for having immunosuppression for lasting for 2 months. And as for the question as when eculizumab should be stopped, so I will go back to the figures here and here. So these patients were all treated with plasma exchanges. And remember, I said that you can stop plasma exchanges after, say, 4 to 6 weeks or even 2 months from onset. So all the time between, say, let's say 6 months to 120 months here is all off plasma exchanges just on immunosuppression. So now imagine a patient who were to have in addition eculizumab as a protection. I think you could probably be safe enough to stop eculizumab by 12 months, because all your relapse risk would be actually covered within that time. Your comparison here is not patients. So you would ask me that what's the data on anti-factor H associated aHUS patients being treated with eculizumab and stopped? And I would tell you that there are 2 papers, one of 10 patients, 7 of those 10 patients where eculizumab has been stopped, and another 4 patients where eculizumab was stopped when their titers fell to 80 to 90% of what it was initially. So, and they don't really have too much follow-up. But that's not the data that we are interested in. What we are interested in is the control data. What happens when you have patients who do not have eculizumab on board, what we call as the natural history of these patients or these relapses. That's our data that we want to understand this concept by. And so if you have eculizumab on board, let's say for 3 to 6 months or even a year, and I guess I will leave Christoph to tell you exactly what the duration of eculizumab therapy should be. But if you have it for 3 to 6 months or even a year, that should be enough to cover these relapses. And then you can just maintain these patients on MMF. But given that the antibody titers are declining, and they have declined to an important extent, so they have to have declined by at least 80% for this concept to work. And so I would end my talk on this slide. This was actually the data from my own thesis on 50 patients with anti-FH associated aHUS, wherein I decided to look at their long-term outcomes in slightly more detail. So all of them had a good eGFR. They were all doing well. But when I looked into it in more detail, most of these patients, a third of these patients had severe ambulatory hypertension, had left ventricular hypertrophy, had reduced functional reserve, had proteinuria. And this was data beyond, it was about 4 years from onset. So, and this was data from our center, wherein these patients were treated adequately within 24 hours of presentation with immunosuppression, did not have relapses. So whatever I have presented, all of these basically long-term cardiovascular and long-term renal outcomes needs to be looked at in minute detail in all of these patients. Long-term, while they're on eculizumab therapy or any other form of therapy, for us to be able to say that we're doing a good job, basically. I think I can skip these because these are just reiteration of what I've already said, and I would end my talk here and take questions. Thank you. Yes.
What is that MMF therapy like?
Oh, sorry. So MMF is mycophenolate mofetil. It's an immunosuppressive agent.
So it's like we have to come to hospital to give that therapy?
No, so it's a oral capsule. It's an oral drug. You can take it orally.
How often they should give? Like, I don't know, just wondering about this.
How it can be given?
Like how often we can give up the frequency?
Twice a day. So it's usually twice a day, and it's a pill that you can take.
So it can be given to small children as well, or like the adult can take?
Yes. So there are syrup formulations as well. So you can give as a syrup. It can be given in all ages.
So no need to give that extra antibodies that we are giving to our kids, like. So instead of eculizumab, after stopping that, we can give this MMF to make them stable, right?
Yes, only in patients with antibody-associated disease.
Okay. So
Not in other. So this agent is an immunosuppressive agent, which basically works on the cells that produce the antibodies. So it's killing those cells, and so therefore these getting rid of the antibodies. Not in other forms of aHUS, other genetic forms of aHUS that do not have antibodies, these immunosuppressive agents are not indicated.
Thank you.
Okay.
I have like a lot of questions, but
Yes,
my first
please.
one is, has your brain always been that fast? I got lost so many times during your talk, but I think one of the things most basically I want to know is what is homology? What does that mean?
So homology is similarity.
I see.
Yeah.
Similarity of cells
Structure.
or I see.
Structure, yeah, I think structure, yes.
Okay. So all the information that you were giving us today was only related to non-genetic anti-factor H.
Anti-factor H associated, yes.
And so that's exactly our son's situation as I understand it. I know you've looked
Yeah.
at his stuff. So I guess what confuses me is if his markers for the actual amount of the antibody are not going down, does that mean that in his case, the eculizumab is not having the effect, or is that sort of independent from the eculizumab?
So I had the slide, but I took it off because I didn't want to have too many slides. But eculizumab blocks the terminal pathway. It does not do anything to the antibody titers. So if you were to have a decline in antibody titers, that would be the natural course of the disease. And it's been shown, and we've seen it in a few of our patients as well, that over time these antibody titers decline. So that's number one. So eculizumab, no effect on antibodies. The MMF is for that. So the MMF is basically acting on the B cells that prevent these antibodies from forming. Yeah. Yes.
When you showed the picture of the peripheral blood slide, and you said by
Yes.
looking at this blood slide you could make the diagnosis of aHUS, what were the factors on that blood slide that said you can do that?
So the diagnosis of aHUS, you would require the presence of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. So this basically points towards the diagnosis. We don't make a diagnosis by it. You need a lot of other stuff as well.
There's a lot of diseases that can give you schistocytes.
Yes, that's true.
So
yes, but then you're definitely thinking hemolysis. Usually when you have patients presenting with just some abdominal pain, vomiting, and nothing really too much, you don't think of this. But when you look at the smear, you are thinking on those lines to check and to make a diagnosis of aHUS if at all that patient has it. Yeah.
I just had a curious question. What's the reason that the percentage of antibodies is so high in India? Is that because it's underdiagnosed relative to the rest of the world and it's making the number appear high, or is there another reason? And just another question related to something you answered before. So I think you alluded to if there's a CFHR1 deletion, the odds are you also have antibodies. Is that correct?
Yeah.
So can one assume that if you have antibodies, you have CFRH1?
Yes, that's true. Yeah.
So then there is a genetic component. Then it may not necessarily just be antibody related.
So the other way around, if you have antibodies, 88 to 90%, 92, that's the figure, percent of patients will have a complete deficiency of CFHR1. That's the other way around of looking at it. And so the reason I don't say that it's a genetic problem is because it's also present in normal individuals. That's the only reason I'm saying that it's not a genetic abnormality.
Okay.
It's abnormal, but it's not, because it's also there in the normal population. So it's a polymorphism, basically.
Okay.
And the first question is that the answer is that even we are stumped.
Oh,
We don't know the answer to that question yet. Yes.
Do you have any? Thanks for a great talk.
Thank you.
It was really brilliant.
Thank you.
Do you have any speculations on why these antibodies, after 2 years, irrespective of the titers, are not disease-causing anymore?
So we did look at this. I don't have the slide for that, but we looked at this in 40 patients, but we looked at this in remission as well as in patients with relapse. But the problem, and we looked at the epitope where it binds and whether that changes, but there was no difference. But then again, the limitation was that we had very few patients with relapse. But we did look at this. We didn't look at the strength of binding, so the avidity we didn't look at that, but we did look at where these were binding. That's the only thing that we have looked at, just to be able to understand whether there is a difference. But the other thing is that when I mentioned the free factor H levels were, so I don't know whether that indirectly says that the avidity might be different in these antibodies in patients who show a relapse later on.
And thank you. And somewhat in follow-up, what is then different with the COVID ones?
So no, we didn't test for any avidity or epitope binding in COVID patients. We do have the samples though.